Hi everyone. Thank you so much for joining us on this webinar today. I'm Sandy Lewis. I'm Chair of GIN North America this year, and I'm happy to welcome you to this November webinar. At this time you should all be muted to ensure that we have a smooth recording. However, you may submit questions via the chat feature at any time during the presentation. We're going to hold all of your questions until the Q&A at the end, however. Today's webinar will be on the topic of assessing the impact of social media on dissemination and implementation of clinical practice guidelines. It's often quoted that scientific breakthroughs take at least 17 years to make it from bench to bedside. That is, to actionable implementation at the point of care. In 2001, the American Academy of Neurology, AAN, initiated a dissemination strategy to improve the awareness of its systematic reviews and clinical practice guidelines. Over succeeding years, the dissemination strategy has been refined, and now it's routinely incorporated. The AAN routinely incorporates a process to consider tools, techniques, and audiences, as well as both traditional and novel methods of guideline dissemination. During this webinar today, our presenters will share the design and results of an AHRQ-funded study that evaluated the effectiveness of both traditional and novel guideline dissemination methods for a guideline on complementary and alternative medicine use in multiple sclerosis. Our presenters today are Pushpa Narana Swamy, an assistant professor of neurology at the Harvard Medical School, Beth Israel Deaconess Medical Center, Boston, Massachusetts, and director of quality improvement in the Department of Neurology at Beth Israel Deaconess Medical Center. She has received her medical degree from Bangalore Medical College in India. She completed her neurology residency at the National Institute of Mental Health and Neurosciences, also in Bangalore, in 1991. Then she moved to the U.S. in 1995 and completed another neurology residency, followed by a fellowship in neuromuscular diseases at the University of Tennessee in Memphis, Tennessee. She's a clinical educator and a researcher with subspecialty training and board certifications in neurology, clinical neurophysiology, neuromuscular diseases. She's a member of the Guideline Development, Dissemination, and Implementation Subcommittee of the American Academy of Neurology, which develops evidence-based guidelines. She also serves on the AAN Practice Committee and Government Relations Committee. She's participated in the development of quality measures in peripheral neuropathy and muscular dystrophy. She chairs the Quality Improvement Committee of the American Association of Neuromuscular and Electrodiagnostic Medicine, and her broad area of research is in health services and includes dissemination and implementation research and other areas related to evidence-based clinical practice guidelines. Pushpa's co-presenter today is Tom Getchis. Tom has been employed since 2005 at the American Academy of Neurology and now is the Director of Clinical Practice. AAN is the world's largest professional association of neurologists with more than 28,000 members. Tom directs the operations and functions of the Practice Committee, its Guideline Development Subcommittee, and its work groups on telemedicine, stroke, and advanced practice provider education in collaboration with volunteer neurologists. Tom is currently serving, thankfully, as the Chair-elect of the GIN North America and Chair of the Subcommittee for this webinar series and social media. He's also about to become Chair of the Council of Medical Specialty Societies Clinical Practice Guideline Component Group at the end of this month. He has co-authored 2 of the AAN Guideline Development Process Manuals and co-authored over 20 peer-reviewed publications related to systematic reviews, guidelines, and guideline research. And so it is my pleasure today to present Pushpa, who will start us on the impact of social media on dissemination and implementation of clinical practice guidelines.
Thank you, Sandra, for that very generous introduction. And thank you all for being on the webinar today. this project was funded in part by an Agency for Healthcare Research and Quality grant. Both Tom and I have received salary support in our roles as co-investigator and primary investigator, respectively. Katie?
Yeah, this is Tom. I'll jump in and say that as we begin this presentation, it's our hope that we can learn from you. There's a number of individuals that are on this poll or on this webinar. So we'd like you, as we advance to the next slide, to tell us if you can take one thing away from this presentation, what would it be? To market or disseminate your guidelines, develop derivative products, learn how to shape and measure the uptake of your guidelines, or to shape your message in the media. So let's go ahead and open that poll now and go ahead and let us know what you're thinking. As Pushpa will talk a little bit about during her talk, we'll share, the process that we went through on this grant and the study design and the methods. And then in the latter half of the talk, I'll focus a little bit more on the operationalization of our guidelines, the derivative products, and educate you a little bit about the process that we use to promote each guideline through traditional methods, novel methods, and social media. So I think we'll end the poll there and
yes.
flip.
Yeah,
So
thank you.
Yeah.
Thank you all for the response. So it looks like about almost equal numbers of people want really to learn to measure uptake of guidelines and also to market and disseminate our guidelines, which I think hopefully we should be able to cover in this hour because our grant proposal was really directly related to both of these questions. So as part of this study, the question that we asked was, what are the most effective and efficient ways to disseminate recommendations from a clinical practice guideline? And in order to study that, we used, as Sandra said, a guideline that we were developing at that time, and this was the first guideline ever developed on complementary and alternative medicine in multiple sclerosis. Because of the popularity of complementary and alternative medicine and also the impact of multiple sclerosis in the community, we decided to use this guideline and develop an innovative dissemination strategy by adding novel social media-based dissemination methods to traditional methods. So the first specific aim was really to just develop a dissemination strategy. And then our second aim was to evaluate whether the addition of social media-based dissemination methods would improve clinical practice guideline awareness in our two major target audiences, and that was patients and physicians. And finally, to evaluate whether the addition of social media-based dissemination methods would affect the implementation of clinical practice guideline recommendations. And we did this in the following manner. So I will talk a little bit more about our outcome measures subsequently, but really this was a longitudinal observational study, and we used quantitative survey methods. The surveys for this to measure our outcome measures were developed by the Dana-Farber Harvard Cancer Center Survey and Data Management Core, and we also beta tested the surveys. So really the design that we used was a before-after between subject survey design, which means we had the two interventions. The first intervention was that the guideline was published and traditional dissemination was started. And I will define shortly what we mean by traditional dissemination. And the co-intervention was novel dissemination. So before the first intervention, that is the start of traditional dissemination, we measured our outcomes using a pre-dissemination or pre-publication survey. We subsequently waited a month after the guideline was published and traditional dissemination was undertaken, and again used a post-traditional dissemination survey. We waited 3 months after the guideline was published and after traditional dissemination was performed, and then went ahead with novel dissemination, which I'll again define. And a month later, we did another set of surveys in our target audiences, the physicians and the patients. And that was a post-novel dissemination survey 1. And finally, 6 months after the dissemination was actually started and 6 months after the guideline was published, we did a final survey. So that was post-novel dissemination survey 2. All of these surveys were done in our 2 populations, that is patients with multiple sclerosis or caregivers of patients with multiple sclerosis, and clinicians who I will refer to as physicians as well, but we also included advanced practice providers with a focus in multiple sclerosis, and I'll talk about that shortly. So we defined traditional methods as print, email, and internet-based methods, excluding social media. And the traditional methods that we used really included the following. So we had the Neurology Journal, which is the official journal of the American Academy of Neurology. We had the guideline published in that journal. We sent out media press releases to almost 700 science and medical reporters. We developed clinician and patient summaries of the recommendations of the clinical practice guidelines, as well as the slide set for education and teaching. We had news articles about the guideline in AN News, and also articles in Neurology Today and Neurology Now. Neurology Today is an AN publication directed towards physicians, whereas Neurology Now is directed towards patients. The clinical practice guideline was highlighted on the AN website. We also sent out emails to all American Academy of Neurology members and to all the section members of the AN, as well as neurology residency program directors and members of BRAINS, which is an AN affiliate for practice managers. We really defined novel dissemination broadly as social media-based methods. And in order to do this, we had an audio podcast on Neurology, the journal, describing the recommendations of the guideline. We also had videos for both patients and physicians posted on YouTube, and the videos had links to the clinical practice guideline on the AN website. We undertook digital advertising on YouTube and also Facebook digital advertising, where we targeted the audience that endorsed an interest in a complementary and alternative medicine in multiple sclerosis and related terms. Tom will talk a little bit more extensively about how we chose the terms, or how we undertook the digital advertising, etc. We also used LinkedIn for digital advertising. And finally, we had a tweet chat on Twitter. And this was in partnership with Time Magazine, the National Multiple Sclerosis Society, and Beth Israel Deaconess Medical Center, Boston, where I work. It was really quite an eye-opener for me, this whole novel dissemination method, because for the first time, I actually opened a Facebook account to figure out what that was all about, and opened a Twitter account to figure out what that was all about. Both during the traditional and novel dissemination periods, we sent out informational emails about the guideline to patient organizations, including the Multiple Sclerosis Association of America, the Multiple Sclerosis Foundation, and the National Multiple Sclerosis Society. So this is our next poll. Tom, Katie, anyone taking this over?
Yep, we'll have we just want a simple yes, no, or unsure if you are disseminating guidelines using any of the social media tactics that Pushpa previously mentioned.
Yeah, I think it would be really interesting to exchange some ideas at the end of the talk about your experiences with social media, because we've had some very interesting results that I will share.
All right, let's close it.
Okay, that's really quite interesting. 2/3 of you are using social media. This will make for a good discussion, I think. Thank you. So in order to obtain our study participants, we drew them from two whole populations. So for the physicians, we used physicians or clinicians, that is advanced practice providers, who treated patients with multiple sclerosis, and they were identified from the AAN membership database, because in the database we usually have to identify an area of our interest, of our clinical interest. We chose neurologists with a focus in multiple sclerosis practice, residing in the USA, obviously, because that was most relevant to the study, age less than 68 years, who had both mailing and email addresses. And in order to increase our chances of getting a response, we did not want to have those who had survey fatigue. So we chose people who had not received any AAN surveys within the past 6 months. We had calculated our sample size based on a 10% response rate and a 20% change in intent as significant. And so we would need about 62 responses to power our study adequately. So we sent out 620 surveys per round of surveys. And for each round, we would exclude the 620 that we had sent the surveys to the previous surveys and send another 620 surveys. Similarly, for patients or caregivers, we identified subjects from the database of subscribers to Neurology Now, the AAN publication directed towards patients. And these were all subscribers who had self-identified an interest in multiple sclerosis. We finally had over 10,000 subscribers. We did need those who had both email addresses and mailing addresses. And again, as per our sample size calculations, we would need 19 responses per survey to power us adequately. And so we sent out 200 surveys in each of the 4 rounds of surveys. So data collection was really done by the Dana-Farber Harvard Cancer Center Survey and Data Management Core. So all participants were contacted by email first and invited to participate, and this within course is the exact way we put it, in a research project examining the effectiveness of different approaches to dissemination of an AAN guideline titled Complementary and Alternative Medicine in Multiple Sclerosis. We provided a link to the online version of the survey. We sent out remainder email invitations to non-respondents after 1 week. And then 1 week after the reminder emails, that is 2 weeks after the surveys actually started, we mailed the surveys in paper format to the remaining non-respondents. And for the physician surveys, in order to increase the likelihood that they would be opened and read, the envelopes were stamped time-sensitive in red ink. 2 weeks after the mailed survey, a final reminder email was sent, and all of the surveys closed a week later. So any responses we got after the 1 week, we did not really consider. So what were our outcome measures? So in each of these surveys, we tried to look at several different outcomes. Our primary outcome was the difference in intent to discuss complementary and alternative medicine with their physicians or patients, respectively, for the two study populations after novel dissemination compared to that after traditional dissemination. So what we were trying to get at was, did intent to discuss CAM change with novel dissemination? The reason we chose intent was knowledge is one measure. However, knowledge doesn't really translate into behavior. Behavior changes may take a while to see, and we were not sure that within the time frame of the study we could actually see this, and therefore we used intent as a surrogate measure. Secondary outcomes that we looked at were, first, just overall awareness of the existence of the CPG. So if somebody doesn't even know that the CPG is around, then it doesn't really matter because knowledge or behavior or intent is really not going to change. We then also measured knowledge of the clinical practice guideline content, and we used a specific question, and that was, they had to give us yes or no answers to the question, to the statement, taking ginkgo biloba orally is useful for improving memory in MS. And this was directly related to a recommendation from the clinical practice guideline. We also measured behavior changes regarding a CAM, whether physicians actually discussed it with their patients, whether patients discussed it with their physicians, or they stopped or started any CAM. And all of these were measured as baseline and after the two dissemination periods, that is a traditional and novel dissemination. However, we also went into each survey. So within each survey, so all of these initially were measured between surveys, but then we looked at each survey and stratified the respondents as those who were aware of the clinical practice guideline and those who were unaware of the clinical practice guideline. And then we looked to see whether knowledge, intent, or behavior was different in the folks who were aware of the clinical practice guideline compared to those who weren't. So let's take a look at the results. We'll take questions at the end, so all right. So we sent out a total of 2,480 surveys to clinicians and 800 surveys to patients or caregivers across all of the 4 surveys. And we had a fairly robust response rate. We were actually quite happy, and that response rate, quite interestingly, stayed very steady across all of the 4 surveys. So for clinicians, we had a total of 622 responses for 25%, and that ranged anywhere from 23 to 27% between surveys. And for patients, we had about 43.5 mean response rate, ranging anywhere from 42 to 45%. And interestingly, approximately equal numbers of participants responded to paper surveys and email surveys. As you'll see, it's about 55% and 50% for clinicians and patients. So that was interesting to us. And that we would have thought that perhaps email surveys may be easier, but it didn't seem that way. So this just shows graphically what I just said, the total number of surveys, the response rates, and across surveys, as you see, as you notice, it stayed reasonably constant. So what were the characteristics, the demographics of our clinician respondents? So the top chart here shows you the age. So again, fairly steady throughout the 4 surveys. This is the pre-dissemination survey in red. The green is the post-traditional dissemination survey. The purple is post-novel dissemination survey. And this is the final 6-month survey, and this is all of the surveys in total in dark blue. So the mean age was 52 years, and with a standard deviation of 9.8 years. Women made up about 35% of respondents, and that pretty much represents the membership distribution of the American Academy of Neurology. And about 3/4 of our respondents were white. This graph here shows internet use less than daily. So really, almost 95% of the clinicians use the internet daily. Our practice focus for our clinician respondents was fairly diverse. About 32% were in group practice, that is this bar here. 21% were in a university-based practice. 19% were in solo practice, so that's here, and then 17% in multi-specialty and lesser numbers across other different practice settings. 62% of the clinicians had been in practice for more than 15 years, so that is this entire area here. It was just 13% of physicians who had been in practice for less than 5 years, so we had a reasonably wide range of experience. And several of the physicians, about 58%, almost 60%, were treating more than 50 patients with multiple sclerosis. We also looked at overall clinician attitudes to guidelines, and we'll talk about awareness in a little bit because that's one of our outcome measures. About 70 to 80% across surveys had read the guideline. Now, we asked them about some general questions regarding whether they discuss AAN guidelines with their patients, and anywhere from 40 to 65% said that, yes, they do use AAN guidelines and discuss them with their patients. About 35 to 40% used patient tools that we create with the guidelines. And specific to this guideline, about 20 to 25% reported a change in practice, and we'll talk about that with our results. So we also looked to see how physicians were accessing the guideline, because that would inform our dissemination process. I mean, are there any specific ways that clinicians like to access the guideline? How do they read the guideline? Where do they hear about the guideline from? Most often it was really through the AAN emails or information from a colleague. That's how they heard about the guideline. And accessing the guideline, about half accessed it through either the AAN email or directly through the AAN website. So I think that was really quite important for us in terms of really making sure that those were the tools that we employed. So we then looked to see what their preferences were in terms of CAM. It was interesting that approximately half the clinicians routinely discussed CAM with their patients. About 51% range across surveys, anywhere from 48 to 56%. It was a minority, about 4%, of clinicians who were unaware if their patients used CAM or not. And the vast majority of clinicians, almost 80%, said that they recommended some form of complementary alternative medicine to their patients. And of the complementary alternative medicines that we surveyed almost 32 different types of CAM, because they had all been covered in the CPG. Yoga, massage therapy, and acupuncture were the therapies that clinicians considered most useful. And again, these were also the 3 therapies that clinicians were most likely to recommend, although slightly different in terms of the order. So yoga was highest that they thought were useful, but they were most likely to recommend massage. In terms of marijuana, again, this was of particular interest because of all of the legalization issues surrounding medical marijuana, and this was part of the guideline. We had made recommendations, and we noted that 52% of clinicians reported that their patients used it, but only 7% said that they would recommend it. So again, these 3 charts, there's a couple more, this and the next slide, summarize really what I said. So these are all of the complementary and alternative medicine that more than 10% of clinicians reported their patients tend to use. And as you see here, massage, acupuncture, and yoga are the top three. And of the ones that they recommend, again, massage, yoga, and acupuncture are the top three. The ones that they believe would be useful, again, yoga, massage, and acupuncture. Similarly, the ones that they would intend to discuss, same, yoga, acupuncture, and massage, slightly different in terms of order, but really those were the three that came up throughout all of the clinician surveys, survey questions. What were the characteristics of a patient population? So our patients, the mean age of our patients, and I don't have a slide here to show that, a chart here to show that, but the mean age was about 55 years, 54.8 years. And if you look at the race and ethnicity chart on the top, about 87% of the respondents were white, and this was about 84 to 89% across surveys. In terms of education, 55% had a college diploma, and almost all patients, that is 99%, had a high school diploma. We had patients who used the internet daily. About 70% used the internet daily, and only a small number, about 10%, said that they used the internet less than once a week. Some disability in use of the internet was reported by about 22% of the patients. In terms of their multiple sclerosis characteristics, over half of the patients, about 56%, reported an MS duration of more than 10 years. It was about less than 5 years in about 17% of respondents. 56% of patients were ambulatory without assistance. About 49% had normal vision, and 44% had no difficulty in use of their hands. So the reason we looked at all of these was to look at confounders and see if any of these could confound the use of social media. For instance, if they couldn't see very well, or they couldn't use their hands very well, perhaps they couldn't use social media. So these were basically to look for confounders in our studies. So we also looked at what CAM therapies they would tend to discuss with their physician, or they had started over the past 6 months. Again, here you see acupuncture, chiropractic therapy, and naturopathic medicine were the ones that they had most frequently started. But what they intended to discuss again was massage therapy, acupuncture, and yoga. What they had recently discussed was acupuncture, dental amalgam, which we actually did not cover in the guideline because there was no data available, and bee venom therapy, which we did cover in the guideline. So the last 3 slides look at the actual analysis of results. We look first at the physicians or clinicians and then at the patients. So this is a slightly complicated slide, but I'll walk you through it. The orange line represents awareness, the blue line is knowledge, the dark red line is intent, and the green line represents behavior. And each of these points represents the pre-dissemination, post-dissemination 1, that is traditional dissemination, post-novel dissemination, and the final survey. And the last group represents the combined data for all surveys. So a dotted line represents significance between 2 points, and the dots here, or the squares, represent differences within surveys here. So if you see a starred dot, that is a significant difference within surveys. So if you look at this, the awareness of the clinical practice guideline increased significantly between the pre-dissemination and the first survey. So traditional dissemination was very effective in increasing awareness of the guidelines. So this was statistically significant. The absolute difference was 36%. However, you will notice that there was really not much of a difference between the awareness after traditional dissemination compared to that after novel dissemination, and it sort of flattened out after that. In terms of intent to discuss CAM with their patients, the intent also increased significantly after traditional dissemination, but did not do so after novel dissemination. So you will remember that this was our primary outcome measure, whether novel dissemination would help to increase the intent to discuss, and we did not meet our primary outcome measure. There was no other change across surveys, but when you look at within surveys, so when we stratified physicians into physicians who are aware of the guideline and those who are not aware of the guideline, aware physicians were more likely to answer the knowledge questions correctly, and aware physicians were perhaps more likely to change behavior as compared to the unaware physicians. So we then looked at the same kind of analytics in our patients. The problem was that, unfortunately, we noticed that only a few patients were aware of the guideline or intended to read the guideline. So this was just 19 patients out of the total of 262 respondents who said that they were aware of the guideline. So we had small numbers, so our results were somewhat difficult to interpret. However, you will notice, similar to the physicians, that between pre-dissemination and traditional dissemination was useful in increasing awareness of the guideline and also intent to discuss CAM with their physicians. However, within survey differences were really not significant, and there was no change in knowledge or in behavior across the patients. So we published this in the Journal of Medical Internet Research recently, and this is a link to the actual article. And I think I stop here, and I will let Tom take over and talk to us a little bit about the actual campaign analysis.
Well, thanks very much, Pushpa. I'm going to continue right on. So for every guideline that we publish, our marketing, communications, and publications team, we sit around the table and develop a marketing plan on the staff level and talk with our physicians and guideline authors about how we execute that plan and how narrow we focus the guideline dissemination or how wide we broadcast that. So this was a wide dissemination, one, in part because it talked about complementary alternative medical therapies and medical marijuana. And two, we know that multiple sclerosis has a high prevalence in neurologic disorders. So we established a benchmark of 10,000 views of the guideline published within 2 months in our journal, Neurology. We met that marketing objective, about 17,500 accesses, and we can get the stats from the journal, and we do on a monthly basis for all the publications that we have, seeing that we had, we published the end of March. So March 24th was the actual publication date, and already you can see in that first month, actually the last week of March, 2,200 on the abstract, about 5,000 on the full text, and just over 2,000 on the PDF. And those numbers declined a little bit over time, but we did meet that marketing objective. So, and here's some of the deliverables. You'll recall on some of the earlier slides, Pushpa talked about the two-phase approach with the traditional dissemination and the novel dissemination. So for phase one, it was all of the email and print and the communications out to the members with no social media. So many of these things Pushpa already talked about. The homepage highlights, we have a leadership update that comes out from our CEO to all of our members on a monthly basis. As soon as the embargo lifts on the journal content, we have an email that goes out within minutes, if not right at the top of the hour, to all of our members. It promotes not only the guideline, we have a little snippet in there about the findings of the guideline, plus promoting all the tools that we developed as part of this. Here's a little bit about what they look like. If you've heard my talk at the Guidelines International Network, the EGAPS conference in March, you'll see some of these things that look familiar, but we try and focus our tone and key message and really establish the Academy of Neurology as a trusted authority and a brand, a trusted brand for a lot of the content, actually all of the content that we develop out of the guidelines area. And after reading through the comprehensive systematic review and the guideline that we developed, we worked with that staff team, which is marketing, public relations, and the guideline staff, along with our key physicians, some of the authors and the leadership of our guideline subcommittee, to tease out some of the key recommendations and really make that the focus of the public campaign and the way that we message a lot of the documents. So you see on the upper right-hand corner the summary document we produced for clinicians and the summary document that we produced for patients and their families, and then a screenshot of what the email looks like. If you're not doing this, I strongly encourage you to preview the emails that you send out to your members on mobile devices. This is a snapshot of what it looks like on the mobile device, and if you're not tailoring your messages for mobile devices, you might have some members that see the subject line or look at the text and, oh, it doesn't render appropriately to my screen, and they might delete that. So I'd encourage you to think about that. I put this up here because I'm going to go to the last slide, back 2 slides, the very bottom one, no social media, that last bullet. When we talked with our marketing and our PR staff, we were collectively, we were concerned that if we don't promote this guideline via social media, is it going to appear that we're actually hiding something? Are we trying to fly under the radar? Because with all the guidelines that we do publish, since social media has become much more prevalent, we do promote via social media. So we thought we needed to be ready. So Pushpa and the lead author and others had to be ready with talking points in the event that any of our media partners or reporters called and asked about why we didn't promote this via social media. Luckily, crisis averted. We had no issues with that, but I tell you that there were no recommendations in our CAM guidelines or our systematic reviews that I think it's the efficacy. There's no recommendation that we make for smoked marijuana. Now I'll tell you that the media message, it didn't necessarily run away from us, but the stoner groups loved us because we made a recommendation for use of medical marijuana to reduce symptoms of spasticity and MS. And at the end of the day, the pot leaf, which you see on the screen, is very provocative, and it can draw your attention. And a lot of those stoner groups, those quote stoner groups, actually used that image or an image like this to really draw attention to the guideline website and the recommendations. We have fairly sophisticated reporting and use of Google Analytics, so we could see when that email, when the embargo lifted, we saw activity from March through May, again referring back to that 10,000 accesses on the neurology page, how people came to the guideline. You saw a little bit of this in Pushpa's slides earlier in the bar graph, but I think this is very telling too, that the average time people spent on the page was 1 minute and 49 seconds, which is about 30 seconds more than they do on any other page on the Academy website. And the entrances to the page came from Google, either a direct search, Bing, or using Informs. Additional web traffic on the multiple sclerosis page. So on the previous slide, we have the guidelines homepage with recent guidelines, and then top entrances if you came through the multiple sclerosis page. And here, if you came to the MS page, it was almost 3 minutes on the page. 5,300 page views, 4,067 unique page views. So those are 4,067 unique individuals that come to the page. The reason I think it's higher for the page views is people like me and my staff and Pushpa and others that go to this page and click on the guidelines a lot, or there's a member question that comes in and I need to search the page to reference some information. So the unique page views is our attempt to not double count those unique visits that come to the site. And again, for coming to the MS page, Google far and away was the way that people came in. And again, notice this is only with traditional messaging. We didn't use any Google AdWords, any Facebook ads for this first 90-day period. We issued a press release that had a number of page views, and people came to that through our press page and our MS guideline page and our home page. We employed something called A/B testing in the subject line. So A/B testing, we took a subset of our general membership. We took a representative sample, a small subset, and we sent out an email to them at, what was it, like 2:57, and to group A and to group B with different subject lines, and we saw those opens in like the first 5 minutes, and whichever subject line garnered the most opens, we then disseminated the member email using that subject line that had the most accesses. We did have a number of major media outlets pick up this press release. Some of these you can see here with CBS News and U.S. News and Health. NBC picks this up. Typically CNN picks up some of our stuff. Los Angeles Times does. This is interesting with April coverage. So we posted the guideline. It published on March 24. Our annual meeting took place mid-April 2014 when this happened, and we were able to cross-promote the systematic review we published in March and cross-promote the guideline that the systematic review in April and the guideline in March. So a lot of these clips, these are, it could be local news stories like the Minneapolis Star Tribune or the little newspaper in my suburb, all the way up through CNN or the LA Times. And if you think of something making it onto the NBC Today Show, maybe the viewership of the Today Show is 50 million individuals, or think about that with like the Washington Post or the New York Times. So if we were to pay to advertise our guidelines in the major media outlets, such as the ones that I mentioned, we would have spent almost $3 million to garner 2.6 billion impressions. So let me come to phase 2, the novel dissemination. Here we employ videos, the podcast, and here we got into digital advertising with Facebook, YouTube, Twitter, and LinkedIn, and emails to the voluntary health associations, the VHAs. We sent them an email like the National MS Society and said, if you're hosting patient meetings, we have tools and resources to help to drive traffic back to our website. The tweet chat, Pushpa already mentioned a number of the partners, including Time Magazine. We had Alice Park moderate that session. Pushpa was one of the content experts I was on for retweeting and asking some guided questions. And we had just a general MS chat over 1 hour, which garnered a number of impressions. So for the videos, the digital advertising, we actually paid for some of those postings to be placed in your news feed, or if you're searching on Google for multiple sclerosis or complementary alternative medical therapies or medical marijuana, we paid money to those advertisers so that our posts or our tweets or our advertisements show up in your feed. And when you click on those, we pay whatever the dollar amount is for the ad buy that we purchased. And what we wrote into the grant was we needed approximately $25,000 to purchase that advertising. So we were essentially buying eyes on our content. So in the digital advertising, it was 3 rounds each at 30 days. So you remember we had 3 months for traditional dissemination, 3 months for novel dissemination, and each month we switched out ad copy or images which linked back to our patient resources or our professional resources, our clinician physician resources, and drove back to AAN.com. We identified Facebook and Twitter as our primary channels. Facebook, Pushpa talked about this in terms of some of the digital advertising. Facebook has a huge following. There's 1 billion people on Facebook. There's 7 billion people in the world. There's 1 billion Facebook accounts. And when we identified our target audiences, we looked at, okay, we need to look at people over 18 and probably under the age of 70. We want to try and find people that have an interest in neurologic diseases or multiple sclerosis or medical marijuana or any of the other indications that we looked at in the guideline, and then some of the recommendations and conclusions that we came in. So we used all those keywords as search terms. If you're thinking about building a lit search in PubMed, we used a lot of that in the Facebook taxonomy to identify kind of the median range of our audience. And I think that was somewhere between 16 to 30 million individuals that we could target with those ads. So when we posted an ad, we allotted that, we took that $26,000 across the 4 channels and allocated $80 per day for the primary channels and $53 per day for the secondary channels. So if you're like me and you wake up at 6 a.m. and you check your email, and then you check your text messages, and then you check the news headlines, and then you check your Facebook, I'm 32, I'm in that millennial generation. I look at Facebook from my bed before I get out and try and start my day. And I look in my news feed, and sometimes I see an advertisement. Sometimes I see it for technology advertisements that I'm interested in if I'm going to buy a new tablet, or I see something for cycling. I am a road cyclist, so I see advertisements for that. And similar to those, for individuals that expressed interest in those areas that we identified, they would see an ad that would look something like this. So again, we switched some of the ads, the visual copy and the ad copy. So in 1 month, in the first month, we looked at the visual copy, how many people clicked on this, and of these 2 images, which garnered more accesses. And then in the second month, we kept the digital copy the same, and then we provided different text. And of the different variations on the text for the advertisements, which one garnered the most clicks. And then we married up the best of the images and the best of the text to run for the third month to really cross-promote. So here's the results. I don't think this would surprise many of you that are familiar with some of the social media, and those that aren't, you'll get a quick crash course like you have in this education that Facebook by far and away had the most impressions and the most clicks. So over those 3 months, almost 50% of our campaign impressions came from Facebook, 1.2 million. Twitter, not even really a close second. It was actually third, because on YouTube we had a number of impressions. It garnered more impressions through less clicks, but if you look at Twitter, it garnered more clicks than impressions. And then LinkedIn, about 600 clicks for 243,000 impressions. So if you look at the total clicks, so people that saw an ad like I showed you on the previous slide or read copy that I previously described, we had 54,000, almost 54,100 clicks, garnering 2.4 million media impressions. And that was all as a result of spending about $26,000 of our dissemination budget. You can see how we broke that out here with the issuing the press release. The digital advertising, I take that back, it wasn't 26, it was about 24,000. And then for the tweet chat, we spent about $350 of that 26,000 on a promoted tweet approximately 1 week before we hosted that tweet chat with Alice Park. So I'll describe a little bit more. It was moderated by Time Magazine. Again, the partners, Harvard Medical School and National MS Society and the American Academy of Neurology. Dr. Yadav was one of the primary authors, and Dr. Narayana Swamy providing clinical input as senior author and kind of PI on this study. Promoted that tweet approximately a week before, spending $350. We emailed it to Neurology Now subscribers interested in MS. That patient magazine, Neurology Now, is in circulation. We publish 6 times a year, so approximately every other month. If you have an interest in neurology or if you are affected by a neurologic disease, you can receive the magazine for free. You sign up and indicate if you are interested in any disease or multiple neurologic diseases, and we're able to access that database. That was about 30,000 people that we sent that email to, and it had a 21% open rate, which is much higher than average. You think about some open rates being 7 or 8%. So this was by the magnitude of 2 or 3 times. And then for the social media posts, there were a lot of retweets by the National MS Society, and then tweets by Alice Park. And here's what it looks like. We had, again, for that $350 that we spent to promote the tweet chat, in 1 hour of hosting this from 11 to 12 Central or 12 to 1 Eastern Time at a specific period of time on August 28th, we had about 1,800 tweets, over 500 participants, and 5 million impressions. And again, if you think about those impressions, like the major media outlets, if I am on Twitter and I have probably 400 followers, so anything that I post, the 400 people that follow me see, and if someone retweets that, it can go to their followers. So you can see how this can be a really big grassroots effort and an exponential reach for little to no money. Again, that $350 promoted tweet. So I know we're at the top of the hour. We have another 30 minutes or so for questions, but I'll tell you a little bit about what changed for the Academy since this project ended. We wrapped up our final report and sent that to AHRQ. It was accepted at the end of October. As Pushpa said, we published in JMIR. You're welcome. These slides are going to be, this presentation is going to be recorded. You could access that link and even find this on LinkedIn on our GIN North America page, where I'll cross-promote again so you can access that article. It's open access, so you can get it free of charge. So there was the shameless plug. Now I'll tell you what we've done since the project has ended. For social media marketing for guidelines, as best we can, and when the topic warrants it, we're using Facebook, Twitter, LinkedIn, and Pinterest. We're doing some advertising on Google, but it really didn't rise to the level where I want to note it on these slides. And then some of the eye-catching imagery, which you saw, the bee sting or the reflexology or the tipped-over bottle of fish oil pills. It might be enough to capture your attention rather than scrolling through a lot of text and make you want to click on that, which would drive traffic back to the Academy's website. Our patient videos on YouTube, we have a fairly active YouTube channel. Sometimes we have informational videos about Academy products, programs, and services. We're starting to record more patient and physician videos on YouTube, placing them on YouTube, but we're finding that the patient videos are much more accessed than some of the clinician videos. We find that patients are meeting us at a lot of the social media outlets. And pushing for more stories in our patient-facing magazine, Neurology Now. It's a separate editorial board. We don't have control over the content. We certainly suggest stories and provide some copy and even individuals that could be interviewed, but it's ultimately their prerogative whether or not they pick it up. And then certainly more rigorous survey design and data collection. So it's been a really interesting and a worthwhile endeavor. We're very grateful to AHRQ for funding that initiative and this study. Happy to share the results here. And I'll move to my last slide here where we can take questions. So Sandy, I'll turn this back over to you.
Okay, thank you very much, Tom, and thank you, Pushpa. You provided us with a lot of very interesting information, good statistics, and a lot to think about. There were several questions that have come up, and if other people have additional questions, please go ahead and submit them in the chat box now. In the meantime, I'm going to start, and I'll let the two of you decide who will answer which question. But I think it would be helpful, this one may be focused for Tom, but I think it would be helpful if you could give us some idea how you select which guidelines will receive these various social media efforts, the novel offerings, also tools that you develop and other derivative products, and any other promotional materials.
Sure, I'll touch on that briefly, and Pushpa, you can add in when I try and wrap up. But when we have a guideline that is selected, it's approved by our guideline subcommittee. We write a protocol. We put that out for public comment. We take public feedback. So that's one area where if we're generating a lot of public interest, it's probably going to be either a standard, which is our middle tier, or a wide dissemination, which is our highest tier. Narrow and focused dissemination is for really niche topics, maybe rare neurologic diseases. So we have the guidelines that are accepted, and every time that the guideline comes to the subcommittee, we talk about not only improving the methodological rigor and the clarity of the conclusions and the recommendations, and does it make sense going from weak evidence to a weak recommendation, strong evidence to a strong recommendation. And then after we talk about the development side and improving that clarity of the written document, we talk about dissemination. Is this solely a neurology topic, or does it touch general practitioners? Does it touch other medical disciplines? Do we need to educate or inform other areas of medicine? And when we talk about that, we have physicians, we have providers, we think about patients, we think about public, we think about users, and we think about policymakers. And is it really important to them, somewhat important to them, not at all important to them? It's very subjective in terms of defining whether it's a wide dissemination all the way through a narrow dissemination effort. But we kind of tally up those results from the different audiences and then determine, okay, for a narrow dissemination, maybe we don't want a press release. We just want to publish the guidelines, send out an email, make our members aware of it, post it on the website, have a nice day. Or standard is, let's think about clinician and patient summaries in a slide set. And really that wide dissemination is when we're going to focus more on paid advertising through social media channels, developing clinician videos, hosting a press conference at our annual meeting. So for each of the levels, we think about what tools and derivative products we want to go with them. And the wider the dissemination, the wider the dissemination level and the greater the reach, the more offerings and tools that we want to develop. So Pushpa, anything to add to that?
I think you really summarized it quite well, Tom. Thank you. The only comment I will add is that the way we tend to decide whether something is going to be a narrow focused dissemination or standard really is very dependent on the topic itself. There are some topics ask a narrow question, more of interest to a neurologist only, and perhaps even to a subset of neurologists, some subspecialists within neurology. Those would probably get narrow dissemination. Whereas some other topics, for instance, CAM and MS, or even something like restless leg syndrome, which is not of interest just to neurologists, but is something that crosses specialty lines, and patients with those disorders are managed by primary care physicians, by sleep medicine doctors, by others. So those kind of guidelines would be typically chosen for wider dissemination. So the subject matter really influences quite a bit which way we would go.
Okay, thank you both. So while we're on the subject of making decisions like this, let me ask about the staffing model that was used to educate this campaign and the research, and how should other groups staff up for this type of campaign?
Well, Pushpa, I could start and you could fill in, at least on the grant side. I can talk a little bit about the dissemination model that we have.
Yeah, sure. Sure.
So so I'm the director of the area. We have a guideline development program manager. We have an editorial assistant in the area. We have an admin that supports all of our work, and then we have a manager of our clinical practice publications. And the 5 of us were really involved on the staff side on this grant in seeing the guideline through all the iterations of the subcommittee, seeing it through when we had all the conversations about dissemination. I also was kind of the point person and the liaison within the academy to talk with our social media mavens to help with the imagery and the copy. We have a writing team in-house that took the key messages and primary messages from our dissemination plan and worked to write all the internal stories. We have a surveys staff. One of those individuals, Carol, who's on the grant, helped us in refining a lot of the survey questions and some of the analysis in-house and checking our samples, pulling the samples for each of the rounds of surveys that we employed. And then we had a marketing manager that helped us with a lot of the different outlets that we had, internal and external, along with a PR, our PR director that helped with drafting that press release, disseminating out to the Academy's contacts and such. On the grant, we had all those staff. We met weekly throughout the entire process, from probably once we got the funding all the way through the analysis and the final submission. And that was the Academy staffing team. Pushpa, do you want to talk about the grant staffing team and the co-investigators?
Sure. So just to take a step back, besides the grant, I mean, generally for the dissemination piece, we also have a team of clinicians who sort of work through the entire dissemination process with the AAN staff in drafting key messages, modifying how to sort of convey the message, and even selection of audiences, etc. So, and that is done by picking a group of clinicians who participated in authoring the guideline, but also picking physicians who are not specifically on the author panel of the guideline, but are related in some way to the guideline by their content expertise, so non-guideline author content expertise. So we get a reasonably wide input regarding key messaging, etc. For this particular grant, we had two other co-investigators and the AAN methodologists who were involved. But at the dissemination level, when it went there, we did have a few others from the panel as well as from the MS community clinicians who took care of patients with MS who were involved in the key messaging.
So for a follow-up, as other groups are considering getting more into some of this more novel dissemination, but they're not going to be part of a grant, do you need any additional expertise on staff beyond what you would have anyway in your guideline development team? And if you're not a medical professional society where there's marketing expertise and public relations expertise and so forth, but you develop guidelines in other settings, are there skill sets that you need to make sure that you add to your staff?
Sure, that's an interesting question. So we were very lucky because the AAN public relations team is extremely media savvy and savvy with social media. For instance, if I had to do it, like I said, this was the first time I opened a Facebook account because I wanted to see what it was all about. As part of my grant, I needed to know exactly what I was doing. So, yes, I think it depends really on the guideline developer. If the developing group has a lot of people who are savvy with social media, for instance, Tom knows all about this. So, if you have someone who's savvy about this, I don't know that you necessarily need to go out and pay for a public relations team to come and do that. But someone needs to really know how these media work and how to leverage them adequately. But I will back up here, and I see one other question here as well, and I'll address that along with this because I think it's very important. Now, you will notice that in our study, we really did not find, we didn't meet our primary outcome. We didn't find that the addition of social media really increased intent to discuss CAM, either for physicians or for patients. And so then you may say, well, should we be even looking at this? So there may be several things going on here, and one of the things we are working on is really looking at subgroup analyses, and we don't have those results quite yet. But then really, we thought of several things that may have influenced this. First of all, this was a little bit different. If outside of a grant, if you were to disseminate guidelines with social media, you would do it all together. You would do the traditional, you would do the novel, all on the day that the guideline was published. It wouldn't be 3 months later. So we wondered, well, maybe the guideline was old news by then and no one was interested. That didn't seem that way because so many people actually accessed the guideline through social media. The point is, though, that perhaps they didn't click through and read the guideline through social media, or maybe it's because our survey respondents didn't use social media, or maybe because our surveys weren't getting at the right questions. So all of these are things that give us pause and tell us, well, we've got to be very careful and we have to continue to look at this and see what is the best way to really use social media to leverage it to disseminate guidelines. I think we really need a little bit more information.
Okay, very good. Anything further from you, Tom, to add to that?
I would say that an email list is a very powerful thing to be able to. It doesn't take any time or energy really to send out an email to your network or to your distribution list to raise awareness. As an individual that has a number of social media accounts on different platforms, it's easy to post a link back to my organization's website or to provide links to interesting articles or other news stories that are being picked up. So I'd say, start somewhere. It can be as small as a link on a Facebook page or sending out a tweet, maybe using specific keywords or hashtags in those social media outlets to try and broaden that reach, and establishing more of an online presence through engaging in these outlets can certainly go a long way when you want to promote your content. Good.
Tom, there was a question about whether you post on the National Guideline Clearinghouse. I want to add to that also and ask, do you post on the Guidelines International Network Library?
So the latter is no, but yes, I should. I just have to get it into the muscle, into the workflow to post. We have a great relationship with the National Guidelines Clearinghouse. We're one of the top 5 posters on their site. We're actually, as Pushpa was talking about, sub-analyses, and we've got a project where we're getting some data from NGC to work on another analysis. But they are very proactive and they reach out to us. They're trolling our website on a weekly basis, and we're publishing a guideline in the beginning of December, and I can imagine that on December 9, we're going to get an email that you publish this guideline. Do you want to put it in the clearinghouse? So yeah, we post there. I just need to get it into the muscle for the GIN library.
Good. So let's talk for a minute about some of the tools and other resources that you develop as derivative products from the guidelines. Do you assess their sales or the number of downloads and other metrics, and whether any of that was increased relative to the introduction of your social media efforts?
You want to talk about that, Pushpa?
Yeah, so in terms of the tools that we developed, the slide set and the clinician summaries and the patient summaries, they're free. So they are actually posted on the AAM website as resources, and they are mailed, depending on the level of dissemination, they're also mailed as print copies to the membership. So it would be hard to track their use because they're freely available and they can be mailed. And I also see another question about how clinicians use them. typically, I think clinicians use them in a wide variety of ways. I myself have used patient summaries, for instance, either print them out and give them to patients, or actually sit down when I'm in the office with patients, just download those summaries and go through them. So either way, I think works. It depends on the patient. I mean, if it's a younger patient who I believe will be fine with looking at it on the computer and maybe even accessing it later, I will do it. I will do it online. Otherwise, I tend to print it up and give it to them so they can read it. So I don't, and as part of this particular grant, no, I don't think we actually track usage of these tools. We tracked as part of, because this is part of traditional dissemination, we track the entire traffic for the guideline itself, but not the usage of the tool.
Okay. So I able to do some tracking of the downloads potentially if they're online resources. But let's talk for a minute about paid ads. When you essentially paid for advertisements, did you get any demographics or other information on those people who clicked on your ads? In other words, besides just total numbers, did you get any information on, say, the age of the users who clicked on the ads or any other demographics?
No, unfortunately, that wasn't available. So no, we didn't get that. We can see, the time periods. So if there was, when we sent out the press release, we see a spike. When there's a Neurology Today article, we see a spike. If there's a major news outlet that's promoting the guideline or picking it up in their news cycle, we typically see a spike. But unfortunately, those demographics, age, gender, location aren't available.
Okay. So can you describe for a minute the tweet chat with Time Magazine moderating and other groups participating? How did that actually work? And is it possible for you to discuss whether Time picked up your press release or not?
So I can talk a little bit about that, where we had our PR staff, again, very savvy. They reached out to Alice Park and Time Magazine. They were interested in hosting a tweet chat, again, that specific date and time and that duration of 60 minutes or that hour, to focus on education of multiple sclerosis, current treatments that are available, trials that are ongoing, resources that are available for patients, what the evidence says and what it doesn't say. So it's not like we had a private room or like an online chat room. It was all the chat was conducted in Twitter, and we used a specific hashtag that we established, MS Chat. Again, there was no cost to establish that hashtag, and we found. I was tracking this much more closely using Hootsuite, which is a software, a web-based platform to track different keywords and content and Twitter handles and some of the analytics. And seeing that we might have asked a question, or Alice Park would ask a question about what is multiple sclerosis. And then Dr. Narayanaswamy and Dr. Yadav were primed to be able to respond with those questions, and then people came in and asked about specific things, and Dr. Yadav was able to respond to that, and it's all in an open and a public forum. But when we use that MS Chat, you can click on that hashtag and it opens up a new browser, and you can see all the tweets from all the people and all the retweets and all the individuals, the companies, the societies, the organizations that were following or contributed to that MS Chat. And again, that didn't cost any money to actually have the chat. It just cost money to promote that chat. So again, Twitter is another powerful way which we're engaging more of in the Guidelines International Network. When there are new articles that publish, we want to try and use the hashtag guidelines or the hashtag EBM or systematic review. Maybe we want to try and loop in the Cochrane collaboration or other high-profile individuals that might actually retweet out to their followers.
Yes. We're trying to continue the discussion we're having today on our social media discussion boards. So people who are participating now, please continue your conversations through tweet and through LinkedIn.
Yeah, we did also advertise, I don't know if you mentioned this, Tom, advertise the tweet chat about a week before. You know, we sort of sent out tweets saying, you know, this is going to happen at such a time, please join in.
Mm-hmm. Mm-hmm.
Okay, and now there's a few other questions here, but I want to get to some important wrap-up questions with only 5 minutes left. Let me ask you, are you planning on continuing to measure these strategies of building awareness and use for this same guideline and for other guidelines?
Yes, that's definitely something that we want to do. There are other things that we are doing now in terms of measurement, because I think it's more and more important to measure the success of our dissemination protocols just to make them more efficient and effective. And then finally, at the end of the day, the whole point of guidelines is to change behavior, to make sure that they are implemented. So yes, that's part of it. Probably not for this guideline, but for ongoing guidelines, yes.
Great. And so are you going to go beyond self-reports when you talk about behavior? Is there another way you're going to look at measuring successful implementation?
Yeah, we have another a colleague who's actually working on this a little bit as well. So we're still trying to tease out the best methods to actually measure outcomes. It's also possible that there may be other more formal ways of doing that, because the American Academy of Neurology recently has started a registry. So within a registry, it's possible to pull that kind of data a little bit more easily in terms of actual usage of guideline recommendations. Additionally, we oftentimes use our guidelines to develop quality measures. So that may be another way to decide how guidelines are changing practice. So yeah, several different ways that we are looking at, yeah.
I think this has been an excellent conversation, and I think we've all learned quite a bit. I do want to say something at the end, but for a final question for both of you. Do you have any recommendations for developers that want to promote their guidelines via social media and have not been engaged in this to now? How to get started?
I would just reiterate what I said earlier and say start somewhere. Start with an email list. I'd put something on a website. You want to have a place where people are coming back to your website or to your journal. The clinician summaries that we develop are typically excerpts from the full clinical practice guideline, which are a quick and easy digestible read for the physician of what's the question we asked, the conclusion, the recommendation in any clinical context or information to put it into perspective. And then again, promote through be like Pushpa, be brave, and create a Facebook account, create a LinkedIn account, start dipping your toe in the water and following individuals, searching for topics that you're interested in, and start somewhere. Promote small and try and grow your network and your relationships and in that manner.
Very good. Well, thank you both very much. This was very interesting. We all enjoyed it. Just for those who may have joined late or would like to listen to this again, as a reminder, we record all of these webinars, and they're all available at the link that's on the slide in front of you now. We've recently revised the GIN website quite a bit, and especially the GIN North America section of that website, so please take a look. Wander around, give us your feedback. As a reminder, there will be no webinar next month. We'll resume this series again in January. But let's continue the conversation on LinkedIn and tweet us at GuidelinesNA. And also today, November 17th is the special day where you can participate in #SaveArc on Twitter. If you're so inclined and you have not yet tweeted about saving ARC, please do so today. Please use the hashtag #SaveArc. And mention in your tweet how the work that you're engaged in today is supported by work that ARC has supported, or that you've benefited from previous ARC funding, ARC tools, methods, and resources. It really helps if you can make your tweets specific. Okay, thank you everyone. We really enjoyed our webinar today, and we hope you did as well. And thank you to our speakers.